So we know that all bowel problems are very common for children with Down syndrome. Around 3% will have an imperforate anus, 5% duodenal atresia, 15% Hirschsprung's disease, 16% celiac disease, but 50 to 70% of children to a greater or lesser degree will have a problem with constipation. So you can see it is really, really common. And so constipation can actually present in a variety of ways. In children, it's not always obvious that they've actually got a problem with constipation. And things we look for, they're pooing less than 3 poos a week, or actually pooing more than 3 times a day. There may be some pain or discomfort when they're doing a poo. They may pass big poos, which are hard to pass and block the toilet, or little pebbles like rabbit droppings, or there may be lots of soiling in between poos. And for older children, they may complain of tummy ache. You may notice them standing to do a poo, not squatting, because when children stand to do a poo, they can actually control their poo more. A lot of children will actually refuse to do a poo on the potty or toilet, maybe because they've had a bad experience of doing a poo and it's hurt their bottom a bit. And we also know sometimes the first sign that there's a problem with constipation when a previously dry child start to have lots of wetting accidents. So I think it's important to recognise that constipation doesn't get better on its own. In fact, it gets worse. Children don't grow out of it. And it's not a benign condition. It should always be taken seriously and treated with laxatives. Dietary advice, fluids, etc., and all the things we're going to talk about are really good at helping prevent constipation. But once constipation is established, as well as doing all the dietary and fluid and potty sitting, etc., then the only thing that you need to do is actually treat with laxatives. And that is really, really important. And the laxatives should be taken at a sufficient dose and for long enough to help prevent the constipation. And it's important that any child who's got a problem with constipation should be reviewed regularly to adjust the dose of the laxative if required, and adjust the dose or type of laxative if the constipation doesn't seem to be resolving. So the correct treatment should enable your child to pass regular soft forms poos. So there is no rigid, this is the only way you treat children with constipation. Every child should be treated individually, and you could have 100 children with constipation and they may well be on different doses, different types of laxative, different combinations, and that is important in successfully treating the constipation. There isn't a standard treatment. There's a basic treatment which we then adjust to each child. And we know that we don't treat constipation in a timely manner. It can become chronic. And then what happens is the child's bottom becomes bunged up with poo, and often they'll have this what's called soiling. So parents will say, oh, he can't be constipated, he poos all the time, there's always poo in his pants. That is a sign of underlying constipation. So why are children with Down syndrome more prone to constipation? It's down to the peristalsis. Peristalsis is the muscular movement that pushes poo through the bowel. And because of often the low abdominal muscle tone, as well as other factors that make children with Down syndrome more prone to constipation, the fact that there's low muscle tone slows everything down. And what happens is that it's not very effective at pushing all the poo out of the large bowel or the colon. And as a result, bits of poo get left behind and eventually all clump together, and the child develops constipation. Because the longer the poo is in the colon, the harder and bigger the poo becomes. The role of the colon, you've got your large colon, and you got large intestine, small intestine, and the large bowel. The poo comes from the small intestine with all the nutrients that have been taken out. So by the time the poo gets to the large bowel, it's very watery, a bit like you would diarrhea, very liquidy. And as it travels along the colon, the water is removed, and that's the function of the colon, to take water back out of the poo. So obviously, the longer the poo is in the colon, the more water is taken out. And so that's another reason why children with Down syndrome are more prone to constipation. It's what we call this slow gut transit. It takes longer than usual for the poo to reach the other end, and so often by the time it reaches the rectum, which is the bottom end of the bowel, it's already hard and obviously then difficult to pass. The thing about constipation, it can develop quite insidiously. You may, as a parent, may not be unaware, you may not be aware that your child actually is developing constipation, because there may not be any signs at the beginning. And because we know children can poo every day and still be constipated. And the first indication that we mentioned might be this overflow soiling or an increase in wetting accidents. Obviously there's other things that you would notice if the child is only pooing once a week, or they're straining and crying when they need to do a poo. So all these factors will give us clue there's constipation. So how do we know if a child is constipated? Well, these are the sort of questions we would ask. And a rule of thumb, we would expect most children to poo no more than 3 times a day and no less than 3 times a week. So if your child is pooing more than 3 times in a day or less than 3 times a week, then that's a good indication there's something going on. But we also want to know, is this functional constipation when there are no underlying medical reasons like celiac or Hirschsprung's disease? So there's certain questions we need to ask. For example, when did they first pass meconium, which is, the dark, sticky poo when the baby's born? It should be passed within 48 hours at the most. When did the constipation start? We know there's trigger times in a child's life when constipation can start, such as weaning and potty training. And so if the child was pooing happily and it was only when you stopped breastfeeding and started weaning, for example, that the constipation started, that reassures us actually that's probably functional constipation and there isn't an underlying problem that needs to be addressed. And as I say, we need to know how often they're doing a poo, what's the consistency. And we usually use the Bristol poo chart, or the Bristol stool form chart, to give its proper name, because then it's easy then if you say, oh, my child's doing type 3 or type 4 or type 6 poo, then everybody knows what the poo looks like. Straining is another indication we look for, and particularly children who are anxious about doing a poo, and if the child stands to do a poo. And sometimes parents will say, he's really, really trying to do a poo. I can see it in his face. And we say, well, what's the position? Are they squatting or standing? And often they'll say, oh, he stands and he's on his tiptoes and holding on to a chair. That child is holding on. They are not trying to do a poo. Because by standing, they're actually squeezing their bottom together and stopping the poo. So we just need to check, particularly if the child's had a problem with constipation quite early on in their life, and there doesn't seem to be a trigger factor that's caused the constipation, or they're on a treatment program and they are not improving. So what we need to do is just a few checks, and these should be done by your GP, just to exclude celiac disease, which is gluten intolerance, lactose intolerance, which obviously is dairy. The key thing is, though, that any exclusion diets, because sometimes parents say, oh, I'm going to stop all dairy, say that's only exclusion diet should only be undertaken under the advice of the healthcare professional, and that is important. And also, that at some stage, particularly if the child's had constipation almost from birth, and it hasn't been done in infancy, somebody needs just to check the child's bottom to make sure everything's in the right place and working as it should. So if you're unsure whether your child's got slow transit time or not, very rough and ready, do it yourself transit study you can do. Obviously, these for children who've been weaned. Encourage your child to eat some sweet corn because the yellow outer kernel is not digested. You then go on poo patrol and check their poos. And what you're looking for is the yellow kernel in their poo and see how long. It should be passed within 12, 48 hours at the very, very most. If it hasn't still passed the sweet corn after 48 hours, that gives us some clue that actually slow transit is an issue. So what are the trigger times children can develop constipation? Well, definitely weaning, stopping breastfeeding. Breast milk has got meconium and other things in it, oligosaccharides, which help keep the poo soft. So stopping breastfeeding, we know for some children, introducing cow's milk can make them constipated. It's to do with the different type of carbohydrate that's in cow's milk as opposed to breast milk. And sometimes reducing formula and breast milk when you're weaning. We know some children are terrible drinkers, and parents have tried every single cup and straw and what you name it to try and get the child to drink. But we know that can be as well a trigger factor for the constipation. And certainly potty training, when the nappies come off and I don't want to poo anywhere but my nappy, thank you very much. And that can cause constipation when they start to hold on to their poo. And of course, the problem is once children start holding onto their poo, even if their poo wasn't hard previously, they're going to make their poo hard. Because, as I say, the longer it's in the bowel, the more water's reabsorbed and the harder the poo becomes. And so when they eventually do a poo, it's going to be uncomfortable because they've got this big hard poo. And what the children are going to do, that's going to put them off an experience of doing another poo. So next time they get the feeling to poo, they think, oh, I'm not going to do that. That hurt my bottom. So they hold on. And before you know, they've got this vicious circle because the more they hold on, the bigger and harder the poo gets. So eventually, nature takes over and they do a poo despite trying to hold on, and it really does hurt their bottom. And before you know it, they're impacted and overflow soiling, etc., etc. So it is important to nip constipation in the bud. And also starting nursery and school, not liking the toilets, upsetting in routine, etc. So one of the questions you ask is, when did the constipation first start? Because that gives us a clue, potential underlying cause. So why is it important to treat constipation? I know a lot of parents are wary of starting laxatives because they've heard this old wives' tale that laxatives in children make the bowel lazy. It is not the laxative that makes the bowel lazy, for want of a better word. It's the constipation. What happens is normally your rectum is empty. The only time you have poo in your rectum is just before you need to open your bowels. Obviously, for children with constipation, the poo stays in their rectum, and the rectum children's bowels are very soft and pliable, and it just stretches to accommodate the poo, and it stretches and stretches. And if you think of a balloon, particularly those sausage balloons, you get them out of the packet and they're long and narrow, and it's really quite difficult actually to inflate. But once you've inflated it, Leave it for a few days, and if the air comes out or you deflate it, the balloon is about 2 or 3 times the size it was in the packet. It doesn't go back to its normal size that it was in the packet. And this is exactly the same for children. If they have chronic constipation, and some of them have it for years and years and years, and it isn't resolved, that bowel gets stretched. And so eventually, when they do get treated or what we call disimpacted, and the bowel is empty, the bowel doesn't suddenly go back to its normal size. It stays baggy and loses its tone. And of course, that makes the child then very prone to relapsing and developing constipation. So what the laxatives do is keep the poo moving. It stops any poo getting stuck in the bowel. It keeps the rectum empty, and that allows and enables the bowel to recover and the tone to come back. If it's not done, then long term, it can cause huge problems in adolescent and adulthood. And unfortunately, there is some morbidity associated with it. And I'm not sure if you're all aware about Richard, a young man who died from chronic constipation. He was in a care home, residential community home, and they didn't address the constipation appropriately. And unfortunately, he died because it compressed he was so full of poo. He was admitted for emergency surgery, but to remove, I think he had, I don't know how many kilos of rock solid poo removed. But unfortunately he died. And unfortunately, he's not the only young man or young person with a learning disability who's died because of constipation. So it is not a trivial thing. It's something that needs treating. Fortunately, deaths like that are, quite rare, but it is something that we need. So I always say, do not be fobbed off by a healthcare professional. If your child is on a treatment for constipation and it's not resolving, you need to go back and get appropriate treatment. So we do a step approach to managing constipation. So obviously, optimize their fluid intake. We look at their diet. We suggest taking probiotics, and things like abdominal massage, cycling, warm baths can all help. Definitely sitting on a potty, it is, as part of their daily routine is important. And encouraging anything which increases the abdominal pressure when they're sitting on the potty, blowing games, that sort of thing. So the NICE guidance, NICE are probably all aware of NICE, but they make recommendations in terms of how much fluid children should drink on a daily basis, depending on their age. And studies have shown that it's not beneficial to drink more than that. But because most children don't drink, sometimes even half of that, we do encourage children to drink up to their recommended amount. And if they won't drink plain water, there's no problem with sugar-free juice, and just to get their child to drink fluid. And certainly dietary adjustments. We do suggest fruits and things which are higher in sorbitol. It is a type of carbohydrate which is in lots of fruits, and it's a natural laxative, and it works by absorbing fluid. It locks the fluid in the poo, so it keeps the poo soft. And it's in dried fruits with stones and berries, and apples and pears. And really, it's something that we strongly recommend for all children, even children who are not constipated, and particularly children with Down syndrome, who tend to be on a lot of antibiotics. Antibiotics obviously help manage and treat infections, but antibiotics also kill good bacteria as well as the bad bacteria. And you need lots of good bacteria in your gut, because the good bacteria in your gut help prevent constipation, and your gut is where your immune system is developed. So probiotics also, as well as resolving and helping resolve constipation, they are also good for boosting children's immunity. And we know it can be produced commercially. If you have a packet of mints, on the side it might say contains sorbitol. Eating in excess will cause diarrhea. As well as, so all the fluids, dietary advice are in combination with the laxative. And by doing that, hopefully it will reduce the amount of laxatives that a child needs. And it's real, children do need this holistic approach to managing the constipation. And we talk about fibre, and I think fibre is important, but I don't know whether you're aware, there's two types of fibre. There's soluble fibre and insoluble fibre. For children with Down syndrome, fruit and veg have usually both types of fibre. But for children with Down syndrome, we recommend have the fruit and veg that have more soluble fibre. Soluble fibre bulks up the poo. It forms a gel-like substance which holds on to water. So it bulks up the poo with water, keeps it soft. So again, it acts like a poo softener. And we know soluble fibre are, a lot of the soluble fibre are also known as prebiotics, and prebiotics is the food, if you like, for the bacteria. Probiotics are the bacteria, and prebiotics are the food that feed the bacteria. And we know it is really helpful in the management of constipation and absorption of nutrients. So insoluble fibre, so you're thinking about bran and things like that. And as the name suggests, insoluble fibre means it's not digested. It adds bulk and weight to the poo. So it is beneficial in the management of constipation, but we know too much insoluble fibre can make the constipation worse in some cases, particularly if there's slow gut. Because if you think about it, if your child's bowel moves quite slowly and the poo that's in the bowel is quite heavy and bulky, that's going to move even more slower through the bowel, hence why it can make the constipation worse. And I just think of a snail trying to push a pebble up a hill. It's going to take a lot of energy and hard work to do that. So and so in terms of dietary advice, we suggest things like porridge instead of Weetabix, things like that. So things that contain more soluble fibre. So insoluble fibre is like wheat and bran, and those sort of root veg and fruit skins and intact whole grains. Well, soluble fibre is like oats and barley, fruit, flax, that sort of thing. And the fermentable ones, these are the prebiotics. The problem with the fermentable fruit and veg is because it ferments, it can produce a lot of wind gas, onions in particular. So we always suggest do not give in excess to children, particularly if they're prone to having a lot of problems with bloating and wind, because obviously we don't want to make it worse. Now, probiotics, you've probably heard us going on and on about probiotics, but they really are beneficial, and they have been shown to be quite effective in helping keep the poo soft, and also as well as boosting the child's immunity. And I think, and particularly children with Hirschsprung's disease, they are prone to a really serious bowel infection called enterocolitis, and probiotics are thought to help reduce or risk the severity of that infection. So we've talked about fluids and diet. So early potty sitting, and we suggest this is introduced from weaning because we know weaning is a trigger factor for constipation. It is, we're not saying you have to start potty training your child at 6 months or whatever. It's a way of introduction to potty training, but really it's about getting your child used to sitting on the potty, but get him in the right position to have a poo. And if your child hasn't got good sitting balance, then, or they're only little and they're too small to sit on a potty or toilet, you can with this you can put your hands underneath their thighs and bring their legs up so the hips are flexed and their knees are bent, and hold them over a potty, particularly if you see them straining. The reason being, it's all about the anorectal angle. This is what the bottom of your bowel looks like. So this is your pelvis, this is your colon, this is your rectum, and obviously the anus, the bum hole is there. And at rest, you've got this muscle, this sling muscle, which causes the angle, they call the anorectal angle. And basically that keeps the poo in your bottom, for want of a better word. But when you squat, when you sit with your knees bent, your feet flat, your knees bent so that your hips flex, your knees bent so your knees are higher than your hips, that straightens that angle, and obviously it makes opening your bowels much easier. And obviously there's squatty potties as well for adults, when suggested you need a high stool so that you can sit in a squat position. And certainly it's the position we recommend for children, particularly if they have problems with constipation and problems opening their bowels. So this just shows you the sort of position that we would want children to sit. And also abdominal massage, particularly before a meal, or cycling the legs up. This all helps get things moving in the tummy. And most health visitors and physiotherapists can show you how to do abdominal massage. But obviously, if your child has had recent surgery or has got a heart condition, always check with a healthcare professional. It's okay to do all that first. There are national guidance, standard guidelines for managing children with constipation. And they've highlighted that children with Down syndrome are particularly prone. And they've also talked about the addition of a stimulant laxative if particularly some children can't take the volume of Movicol or Cosmocol or any other Macrogol, because obviously you have to mix it with water. But there are a range of laxatives if your child isn't able to tolerate Movicol, and if a poo softener alone fails to resolve the constipation, then do have a chat with the GP or pediatrician about the addition of a stimulant laxative. The poo softeners are great at keeping the poo nice and soft, but if there isn't enough oomph in the child's bowel to push it all out, then that's when you need the combination of a stimulant laxative. So the poo softeners keep the poo soft, and the stimulant laxatives push it out. So NICE has just updated their guidelines so it's in August this year, for prescribing information. So if your GP says, oh, I can't prescribe Movicol, or I can't because of his age or her age or what have you, give him the evidence. Yes, you can. A lot of the medications for children are what's called off-label. And what that means is that they may say give from age 5, but it'll be in tiny little print unless prescribed by a medical practitioner. And that's because years ago, all the studies that they did and the research and the randomized controlled trials, they did of children of a certain age. And they found to be really, really effective. And then clinical practice. I mean, I've been using Movicol in children, in babies, for gosh, must be nearly 20 years. And like somebody says, you don't have a randomized control trial for parachutes because you know they work. And that's the same for a lot of the laxatives. We know they work, we know they're safe for younger children. And so the manufacturers are not going to go to the expense of running clinical trials just to lower the license age. And so NICE has acknowledged that and make recommendations. And the only thing is, you know, as long as parents are aware, okay, it says it's licensed from age 5, but actually you can give it from age 6 months or from age 1 month. Clinically, it's been proven absolutely safe and absolutely fine. So I think it is important that your child gets the right treatment. And so, as I said, laxatives are really, really important. And we start off with Macrogols. Lactulose only if the child cannot tolerate Macrogols, but there are things like docusate sodium, which we would recommend other than the lactulose. Lactulose is a chemical sugar. It's quite sticky and it's very sweet. It tends to stick to the children's teeth, so it puts them risk of dental caries. So if your child is on lactulose and it's working, don't stop. If it ain't broke, don't fix it. But make sure after they've had the lactulose, they have water to drink to rinse their mouth out. And because it's a chemical sugar, the bacteria in the gut feed on it. And when they feed on it, they produce a lot of wind, a lot of gas. And so for some children, the lactulose is not tolerated because it makes them quite uncomfortable because they get quite bloated and distended with all the wind. So, and that's another reason why we don't suggest lactulose first-line treatment. So Macrogols, first-line treatment. And if no improvement at the optimum dose, then it should consider adding in a stimulant laxative. And NICE make clear guideline that if despite, you know, best optimum treatment, maybe with a softener and a stimulant laxative, if after 3 months of treatment your child's constipation is still not being removed, they should be referred to a healthcare professional with expertise. Now that could be a specialist nurse or a pediatric gastroenterologist. Again, don't be fobbed off if the treatment after 3 months isn't improving. We have got to stop this constipation becoming a chronic problem because, as I say, it can cause problems over on. So depending on your GP practice, you may be prescribed Cosmocol, Laxido, Movicol. It's really important that each sachet is mixed with water first, because the water then becomes the active ingredient. That water that's mixed with the Movicol or Cosmocol or Laxido then gets locked within the child's poo as it's being formed. And no matter how long the poo sits in the colon, because the water in the poo is locked in, it can't be pulled out and the poo stays soft. Because it's working on the poo as it's being formed, it can take a couple of days to have a full effect. And so what we suggest is do not adjust the dose more frequently than every second day or so to enable you to get the optimum dose. Stimulant max and softeners only work on their poo, it's Macrogol, macro, that means big. It's the molecules are too big to be absorbed into the body. It only works on the child's poo. The stimulant laxatives work differently. They are absorbed into the body, so they work much, much quicker, and they work on the muscle of the bowel. And what they do, they increase peristalsis, give a bit more oomph. And because in theory, they work within 12 hours, it can make the poo more predictable. That's the theory. In practice, sometimes it can take 24 hours. Again, every child's different. So sometimes it's trial and error. You may be advised to give the stimulant laxative on evening. In the theory, they will poo the next morning, but that may not happen. And what you don't want is for the child to poo in the middle of the day in school. So it may be that, we play around with the timing so that they poo at a more optimum time. And as I say, what the Macrogols do, they help keep the poo soft. Once made up, it can be kept in the fridge for 24 hours. So if your child's on half a sachet, you make a whole sachet, give the child half, and the other half kept in the fridge for the next day. To make it more palatable, you can add juice. The manufacturers do not make any recommendations about mixing it with milk or food or what have you. But in theory, if your child won't take it, and if the only way to get your child to take it, and they're going to eat all their porridge, is to mix it with that. And what we suggest is that you mix it in the smallest mix that you can to make sure that they take it all. And the usual starting dose is the sachet, and the adjusting as necessary. And parents will say, well, how do I know if I need to increase or decrease? Well, your child's poo will tell you when you need to. And that's the only thing we go by is the consistency of the child's poo. If your child is on one sachet Movicol a day and they're doing a type 4 poo every day, no problems. Your child needs that one sachet. It doesn't mean, it's the constipation is sorted. It's only because your child is on one sachet that they're doing type 4 poos. So you need to stay, and the only way you would consider reducing the dose if suddenly your child starts passing type 5 poos. So that tells you that's good. The bowel is starting to recover, the peristalsis is increasing, and so you can start to gradually reduce. And conversely, if happily, one sachet a day and happily doing type 4 poos, and then suddenly they miss a day, they're passing type 3 poos, and you think, is constipation starting again? What's happening? They're not eating all their fruit, they're not doing this, not doing that. Then just increase by half a sachet just to get them back on track. And some children may need to stay on laxatives for a long time, years. Some children need to take constantly, and what we usually suggest is at least 3 to 6 months after the initial episode of constipation to help prevent that relapse. And I say, the child's consistency will help in terms of adjusting the dose. If oral laxatives don't work, for some children, particularly if they've had an underlying bowel condition such as an anorectal malformation or Hirschsprung disease, they may also need the addition of rectal, such as glycerin suppositories, and particularly in infants it's useful, particularly if a child is come very distressed and struggling to do a poo. We also know that refusing to do the poo is very common in typically developing children as well. And actually there's a whole industry out there of booklets, leaflets, advice in terms of what to do because my child won't poo. And I think we need to just suss out that there's actually why doesn't the child want to poo, or why are they always wanting to stand, or why don't they want to sit to poo? And we know that if children have passed a large hard poo, they can get a little tear in their bottom called an anal fissure. And this is really quite painful when the child feels that they need to do a poo, and they know it's going to hurt. And so they will do their best not to do a poo. And of course, obviously, they don't realise they're making the problem worse by holding on, because when they eventually do poo, their poo will be bigger and harder, and it will be more uncomfortable. And sometimes you may see a streak of blood on the outside of a child's poo. There may be, if you look at the child's bottom, there may be a tiny little skin tag by their bottom, and that is suggestive of a healed. But if you think that your child has got an anal fissure, you can always ask your GP or paediatrician just have a quick check. There is no treatment as such, other than making sure the poo is kept really, really soft. And sometimes we'll increase, if they're on a poo softener, we will increase the dose so the poo is like a type 5, like mushy Weetabix. So it's much easier to pass. And sometimes rubbing Vaseline around their bottom when they're trying to do a poo can help. And the GP may be able to give you some medication as well to put around the bottom, but it does heal on its own. So it's although it's painful for the child, you know, it does heal and go away. So I think the important thing is to make the bathroom nice and very inviting, and making it fun going to the toilet. And you know we use bribery and rewards for doing poos. Poos mean prizes, etc. So key points, I think, to remember: constipation is very common. Laxative treatment is always required, often long term. And we need to add in the other therapies such as dietary adjustment, probiotics, and regular potty sitting. The laxative dose should be adjusted as necessary, and the addition of a stimulant laxative may be required. And if it fails to resolve, we need to just check there isn't anything else going on, and further referral should be made if the constipation fails to resolve. We have got an information leaflet, if you're not aware of it, on the Down Syndrome UK website. Do have a look on the Down Syndrome UK website, particularly on the toilet training page, because there's lots of information all about toileting issues, as well as where our leaflet is.